Good evening, everybody who are watching this program from India, and good morning to those who are watching it from the United States. Welcome all of you to the live program number 163 at Orthopedic Principles. Today, our guest of honor is Dr. Jorge Villafuerte from the United States. Dr. George is a clinical instructor in orthopedic surgery at the Harvard Medical School and an assistant professor in orthopedic surgery at the Boston University Medical School. He's also the chief of orthopedic surgery at the VA Boston Healthcare System. Dr. Villafuerte received his MD from the Universidad de Costa Rica and completed a residency specializing in orthopedics. He's done several fellowships around the world, including at the Northern General Hospital NHS Sheffield, the hand and upper extremity surgery through the Tufts University at New England Medical Center and the New England Baptist Hospital, sports medicine joint replacement through Harvard Medical School at the Massachusetts General Hospital and the Boston General Hospital. After obtaining his full medical license in Massachusetts, he joined the VA Boston Healthcare System and also served as a teaching faculty for orthopedic residents from the Boston University and Harvard Medical School. He was awarded the 2014 Resident Teaching Award from the Boston University. In 2013, August, he was also certified by the American Board of Orthopedics. Today is my great honor to introduce you to Dr. Jorge Villafuerte from the United States. Over to you, Dr. Villafuerte.
Okay, well, thank you very much, Dr. Kapalan and Sintel, for the invitation. It's really an honor for me to give you this opportunity. And my pleasure to share with you my humble experience with the anterior approach. So this talk we'll be talking about the improved preparative outcomes of the anterior approach at the VA Boston. This is our experience. So pretty much since the total hip replacement were performed, that changed the orthopedic practice for us. It's been advocating all the surgeons to improve the pretty much the aesthetics and something major changes, but not major changes has been performed lately since the surgery were done. Many surgeons try to do the same approach with minimal incision technique, like Dr. Skolko, Dr. Richard Berger, who does this minimal invasive at the beginning, and Dr. Mears with 2 incision technique. But all this surgery came and pretty much disappeared with time because of many complications, risk of the surgical technique were difficult to do, and many people start doing it and stops. But I think the anterior approach came more to stay. But the only problem is the anterior approach is being used more for marketing. And now pretty much my residents learn more the anterior approach than the posterior approach. And pretty much if you have a fellowship train, if you don't know anterior approach, you'll be in a better shape to get a job if you know the anterior approach and the posterior approach. And as you can see, you can go into the internet, you can see thousands of hits about anterior approach because everybody's using it for marketing. And this surgeon, Mohan, did a study who reviewed all the online information regarding the anterior approach. And the problem with that is some patients get incomplete information and misleading patient education materials, and shows only the benefits. So that can be a misleading information, more when the surgeon is starting with the at the beginning of the learning curve, because I think after you do hundreds of cases, pretty much the complication rate decreased substantially. And so one of the questions you ask for yourself when you start doing anterior approach is, why did I change after 11 years of using posterior approach? So I was a surgeon like most of us doing posterior approach, minor complications like everybody else. And now all of a sudden I say, okay, I should do anterior approach. Why I did it? So my colleague who was working with me decided to change 2 years before me. And all of a sudden, after a year and a half, I see that my patient, that I see the decrease of the patient that wants to have the posterior approach with me. And most of the patient wants to go with him with the posterior approach because the patient came and asked for it. So that's one of the reasons. And the second reason, I took the course, I did academic practice and everything, but I didn't start that time. That was a year and a half after my colleague starts his practice. But 3 years ago, my mom developed end-stage osteoarthritis. I went back home to Costa Rica, and with my teachers there, we did a posterior approach. And I spent the first 2 days with her, helping her with the first rehab. And I saw how difficult it is for the patient to recover in the first 24 hours, 48 hours. They use the abduction brace, they cannot, urinate, and all this stuff is very uncomfortable for the patient. Usually us as a surgeon, we come in and out, like, how are you doing? And we go out very quickly. We don't see how difficult it is for the patient, the immediate post-op. And I said, you know what, if I can change the, make my patients more comfortable, I should change the approach, and I decide to change. The problem is this: when I start changing, after 10 cases, I start getting in trouble, and trouble that I never see at the beginning, when I was doing my own posterior approach, because my technique was, I got what's comfortable with the posterior approach. I never see that. So I got upset and I said, why I change? I shouldn't change this approach. I should stay with the posterior approach. I was comfortable. But anyways, if you continue and you persevere with the approach, you can see that the learning curve gets better. And after 50 cases, you can feel comfortable doing the anterior approach. Pretty much this approach, as you know, has been performed for years, since the 18th century. It was done by Dr. Herder. It described the anterior approach, which is the approach between the tension of the fascia lata and the sartorius. After that, Dr. Judes, the brother Judes, started using this acrylic implant, using the same approach. But I think Dr. Smith-Peterson at MGH, using this implant, showed this approach and describe it very well on his paper. But I think the surgeon who really started performing a total hip replacement with the anterior approach, Dr. Christoph Kegi in Connecticut. And since 1980, he shows thousands of cases with the direct anterior approach with good results without the table. As you know, this direct anterior approach can be performed with the table, described very well by Dr. Mata. Or you can use the direct anterior approach without the table. Either way, you can, if you master the technique, that's pretty much the most important thing. You can see that Dr. Nogler in this paper describing the direct anterior approach without using a fracture table. Pretty much this approach shows there's a real intermuscular and intervenous plane. There's a less soft tissue damage, less risk of dislocation. That shows a rapid recovery, avoid posterior precautions, shorter OR time after learning curve is done, and the patient's asking for it. So pretty much if you go anywhere, the patient comes to you and asks, do you do anterior approach? And they're gonna go with you. If you don't do it, they're gonna go to to the surgeon who's across the street who does posterior direct anterior approach. So reviewing a little bit of the literature, in this paper, Dr. Hamilton shows when you do the anterior approach, the position of the components are being placed in a better position, and in terms of the cup, putting the cup in 20-30 degrees anteversion and 40 to 45 degrees abduction is in a better place. You can see the blue points there is better than the posterior approach. One of the reasons of this is because the anterior approach, personally, I'll use a C-arm, so you can really see where the cup is being placed, and you can really modify that immediately. When the posterior approach, personally, I don't use the C-arm. And in this paper, he explained the same situation. And in my review, I saw the same issues. In the posterior approach, I never use a C-arm, but I think if I use a C-arm, I can see the benefit and I can put the cup in a better place. I don't know about the anteversion. It's a little harder to see with the C-arm and the lateral approach than the posterior approach, but I think the C-arm makes a big difference in terms of that. On this review, Mr. Sawatsky shows that the patient that you do with the anterior approach, you can really send them home faster, and the OR time at the beginning of the learning curve is slower, but after 50 cases, you can see the difference that you can decrease the OR time, you can send the patients home faster, you can decrease the length of stay, and he really make a difference between the first 50 cases, he says in this paper, the 50 learning curve and the anterior routine, because after 50 cases, the anterior point becomes a routine. I think 50 is a good number. And I think 50 is a good number if you're an experienced surgeon after 10 years or so doing a posterior approach. But I think if you come out from the residence, if you don't have experience of the posterior approach or anterior approach yet, I think 100 is a good number in terms of 50 instead of 50. But and this review, but Dr. Wilson shows that the anterior approach doesn't come with free issues like I have at the beginning. At the beginning of the learning curve, in the first 50 cases, the patient needs to know that you start doing these cases because she's going to be exposed to some issues, like I did. I have some cases with small femur trunk fractures. In this case, you can see that the early complications of cases as this 8 there, femoral shaft fractures, proximal femoral greater trochanteric fracture, 14 cases, deep infections 2, nerve palsies. So this isn't an issue. And the patient needs to know this. It can be a cost for the patient and for the surgeon when you change the approach. But I think it makes a difference long term. But it's a cost that some of the patients might have to pay if they really want to have the surgery performed. Um, Another thing is on obese patients. In this review, Dr. Russo shows that in obese patients, you can have major complications. You're exposed the patient to more wound complications, increases surgical time by 12.7 minutes. Length of stays increase, use of narcotics are increased. Pretty much, personally, I don't do direct anterior approach when the BMI is above 40. And when the panus is big, when the wound is covered by the panus, I just don't do direct anterior approach in those patients to decrease the risk of those complications. So pretty much what I'm telling you is the direct anterior approach is not, in my hands, is not for all the patients. In general, morbidly obese patients, I don't do. Muscular patients, as well as patients with a short femoral neck or acetabular protrusion, can represent particular problems when you do anterior approach, more at the beginning of the learning curve, because the release of the femur is a little harder to perform when the femoral neck is very short, because it's more difficult to see because you don't have much space. When you have a long neck angle, it's easier to do the femoral release. Uh, in terms of how to learn the technique, it's very well described. You have to master the surgical technique. You have to study with videos. You have to train with cadaver. You have to visit a surgeon who performs high volume of cases so you can really get a feel of the technique. You have to start doing the cases, and it's better to do at the beginning of the cases some with a surgeon who can really help you, guide you through the case at the beginning for the first couple of cases, if you can. In general, no study has shown that this surgical technique is worse than any current approach. Parbisi was very nice to give me this paper that he reviewed. He reviewed 50 cases with the direct anterior approach, with the anterolateral approach at Rotman Institute. And in his paper, he showed that the time to go up and go is better with the direct anterior approach. The gait speed is better with the direct anterior approach, as well as the chair test. So pretty much the patients at the beginning, as soon as surgery is performed, can have a better quality of life immediately. So it makes a big change for the first 6 weeks after surgery. The lower extremity functional score is better with the direct anterior approach. They can go back to work faster. They can return to driving faster. So you can see they can go back to their own activities faster. So the direct anterior approach makes a big difference at the beginning of this, and the immediate post-op, pretty much in the first 6 weeks to 3 months. So at the conclusion of his review, he said that the direct anterior approach decreased the blood loss, less pain, decreased length of stay. The patient has a rapid functional recovery, and they have a less surgical time. So in this video that he nicely showed me, I went to see him. I pretty much used the technique that he is using. You can really clinically feel for leg length discrepancy. Currently, what I do is I put a cardiac lead on the opposite medial malleolus, so I can feel the medial malleolus, and I can clinically feel the leg length of the lower extremities to make sure this is perfect. That's one of the reasons I don't use the fracture table, because with the fracture table, I see that clinically you can do that. There's other ways that they do it. I personally don't use the table for this reason. And the second reason I don't use the table is because you need to have somebody who mastered the use of the table, because if you don't have somebody who knows how to mobilize the leg, you can get in trouble during the surgery. So that's why I don't use that, because I don't have somebody next to me always for every case. If you have somebody that can be with you, that control the table, knows how to use the fracture table, you're less likely will be in trouble. But if you have somebody, change nurses, nurses goes in different specialties, it's more difficult to have somebody who knows how to use the fracture table. So I'm going to show you a little bit of my personal techniques. So I just prep one leg like Dr. Parbisi does. So I pretty much put my right hand for the right hip on top of the SIS. So it's 1 centimeter distal to the SIS, 1 centimeter lateral to the SIS. I use the incision about 8 to 10 centimeters. As you can see here. So you are pretty much with one hand, right hand on the right hip, and left hand on the left hip. I don't use a lot of instruments, pretty much use 2 cobras, 2 hips, 2 self-retainers. The hook is my best friend because this is the one who I use to pull the femur to do the femoral release. So you can see there's not a lot of instruments to use for the direct anterior approach. So you open the fascia there, and you can develop the plane between the tensor of the fascia lata and the sartorius, and you use the hips to mobilize the rectus medially and TFL laterally. As you can see, the lateral circumflex vessels, you make sure you coagulate those. As soon as you coagulate those vessels, you just open the deep fascia, coagulate the vessels, and you're on the pericapsular fat, and you have the capsule right in front of you. I use a cobra on the inferior part of the neck and a cobra on the superior part of the neck. At the beginning, I debate how to use the capsulectomy. I was removing the capsule, but when I was with Dr. Parvisi, he asked me, "How do you do it? You release the capsule?" And he said, "No, it's a good idea to keep it, because if you can keep it, use it for 2 reasons. You can put back the capsule, so use another layer to keep the hematoma in place. And another thing I use it personally is to see how much leg length is increasing, because if the capsule is too tight, when you release it, you know that you increase the leg length or the offset. So you can really control how much length you increase by keeping the capsule in place. So you have another layer for stability, and you have another layer to keep the hematoma in place. So now what I do is I use like a proximal release, proximal capsulectomy, leaving the base of the capsule distally. And at the end of the case, I suture the capsule back in place. So this is released at the beginning. I was releasing in the middle. Now I don't do that. I just leave it. I look like a trapezoid cut proximally, leaving the base distally. So now I put the cobra interarticularly, and you have the neck in front of you. One of the mistakes that is very well described at the beginning of the learning curve is doing the femoral neck very proximally. So when you do that, the problem with this is when you start getting into the femur, you start making a releases pretty much on this area right here. So when you're right on this area, you think you're releasing the femur, and you really have to go behind the greater trunk to be able to get the femoral release. So what I do personally, I'm gonna go back here a little bit. Right after I do the capsular release, I do a superlateral release of the capsule. By doing that, I can really put a cobra right around the greater trochanter when I start doing the femoral release. So because if you don't do this lateral release from the beginning, you might be around the fossa and you think you're making a release, and the femur never goes back. It's half an hour, 45 minutes, you start sweating, and you start saying, why I doing this? Why I'm here? I shouldn't be doing this. And that's when you get into trouble. So at the beginning, you have to do a posterolateral release, lateral release here, so you can really feel that you're around the greater trochanter. So when you start doing the release, you know that the femur is coming up. And you can see this is the correction of the cut right after you go back. This is the right place to do the cut. So when you know that you are around the greater trochanter, the release is around the greater troch. So you have to really go around the greater troch so the femur can go up. So pretty much I do the as a napkin ring cut, and the femoral head comes up with the corkscrew. Now, now you have the acetabulum in front of you. As you can see, I use 2 cobras, and 1 cobra grows right on top of the transverse acetabulum ligament. Another cobra I put is laterally, so I make a release between the capsule and the labrum, and I put a cobra laterally there. So you can see the cobra goes laterally, another cobra medially, and you can have just acetabulum right in front of you, and you do the job for the cup like we all do. And when you prepare the cup, fix it, and put the implants in place. As you can see right there with 2 cobras. I personally I use another two persons to help there. Pretty much I have somebody across the table holding this medial retractor, and someone else holding this second retractor there laterally, the another cobra laterally. Well, now it's time to come for the femur. So what I use is pretty much putting a cobra right where I did the first lateral release. So when I pretty much put my finger across the greater trochanter, so I know that I can go around the greater trochanter. When I'm around the greater trochanter, I start making a release, and I use my bone hook to pull the femoral neck, so you can really pull the femoral neck and see where the release has to be performed. Pretty much the description is, if you have the right hip, This corner here is 12. This the calcar here is 6. So this release has to go from 12 to 3, pretty much. This is the release from 12 to 3. So pretty much the obturator internals, which you can see right here, you don't release. You don't have to release that. Some people describe 3 phases of release. The phase 1 is the one that I described at the beginning. When you don't release, you're not around the great trochanter, you don't release anything, and nothing is moving. 45 minutes, you're sweating and nothing is happening. This is the first stage. The stage 2 is when you release everything. You come back here, you release from 12 to 3, you pass to even 5, and you release everything. So now the problem with that is the second stage is you make the hip unstable posteriorly. So now you have a multidirectional instability. That becomes an issue. That's the second stage. And now in those cases, when you get into that situation is when you have to really increase the length, increase the offset to provide some stability of that hip, because this hip becomes unstable in both directions. Now the stage 3 is when you do a titrated release. When you do a titrated release, you start releasing from 12, you go back and you stop around 3. You don't have to release the obturator internals, and you stop right here, and the femur comes up very nicely. Pretty much the great trochanter is behind this corner right here. So when you release all the fibers around the great trochanter is when the femur comes up, and you put the runabout retractor, and you can lift the femur up, and you are able to prep the femur. I lower my leg about 30 degrees. At the beginning, I was lowering like 60 degrees. I was pulling my patient out of the table at the beginning to be able to do the release and get the femur up. But after, you get 15 cases, 20 cases, you have a better ability to do the cases, and you get more comfortable, and you can just, that you don't have to really lower the leg too much. By 20 to 30 degrees is enough to get the femur exposed. Now, what I do is I use a rat tail and to find the canal. I don't use chili pepper because I don't like to use a brooch at the beginning. I like to find the canal with the rat tail and really rasp immediately. The implant that I use is a ML taper, so I rasp medial to the carcar and lateral to the lateral side of the femur. So I rasp until I feel the cortical bone. When I feel the cortical bone and I know where I'm located, I start using my rasp. So that decreases the ability, of having a complication of going up in the wrong way. And besides that, if you have the C-arm, one of the complications that has been well described is going a wrong way when you start putting the brooches in place. So going pretty much medially on the femur, and you can get an intraoperative fracture. You don't want to have that. So pretty much the motion of the rasp are 3. That's what I described this to my residents. You have to get the handle in internal rotation because it's too much pressure pushing your handle in external rotation. You have to get the handle down to decrease the possibility of getting into varus, and you have to get the rasp as close as you can to the patient's body. That's what some authors describing. You have to hug the patient. You have to push the handle as close as you can to the patient, put the handle laterally as laterally as you can to avoid varus, and hold it in internal rotation to avoid the implant to go in external rotation because of the pressure of the leg. After you put it in the right place, you test it, make sure you template. For me, templating is the key because you have to know which sites you have to put into that patient's body. Because another complication well described is subsidence. If you don't put the implant because of the pressure, sometimes you put it in the wrong, by millimeters, you're in the wrong way. You feel that the femur is tight and it's not. And after the patient start walking, the implant can subside. I have some cases they have a minimal subsidence. The taper implant stops, but it's becoming a problem because you can have a little shortening on the lower extremity. The beauty of the anterior approach that you can see, you can test for stability. You can test for posterior stability with all the directions. Pretty much you can flex, internal rotated, flex, internal rotated, any direction you want, extension. And you can really feel that the hip is very stable. That's the difference with with using the table. But I haven't learned that technique, but I'm afraid that you won't be able to test for stability the same way you do without the table. more at the beginning of the learning curve, I think it's extremely important to keep the leg very stable and feel it that you're stable so you can make the appropriate changes. After that, pretty much I close the capsule with Vicor number 1, or you can use PDS and a running stitch for the fascia, and the case is pretty much done. And you can see clinically that the leg length is appropriate in both lower extremities, the same as Parbisi described on his paper, and he does it. You can see clinically. What I do now, as I told you before, I put a cardiac leak on the medial malleolus on the opposite leg, so you can feel where is the location of the medial malleolus. So because this leg is covered, so you can feel the leg length right after the case is, intraoperatively. So you can see the post-op films and the leg length that is okay there. Pretty much in the review that we did, we decided to review our cases, and we did a retrospective study from 2012 to 2018. Review 121 posterior patients with posterior approach with 93 anterior approach. 88 cases with 104 were reviewed because we have a good x-rays to review. And we reviewed the plain films and measures double inclination, leg discrepancy, and offset. There were similar patients in terms of age, laterality, and ASA score. They were similar in both cases. As you can see, the duration of the surgery were longer on the direct anterior approach, but I see that now my direct anterior approach time is a lot less. After pretty much you do 100 cases, your time decreased substantially. At the beginning of the learning curve, you can spend sometimes 3 hours there. You see that it's a long time to do the case because you have to master the technique. So pretty much when you do the first 50 that is included in this paper, at the beginning is a longer surgical time, as well as blood loss, because at the beginning when you do posterior approach, the posterior approach, I was used to releasing everything. As you can, I was able to see the whole socket in front of me very open. But with the direct anterior approach, you don't do that. And at the beginning of the learning curve, you start doing, you get the feeling that you're changing the posterior approach to the anterior approach, and that's not the case. On the anterior approach, you really feel where the socket is. You don't really see much. You can feel it more than see. So at the beginning, I was releasing inferior capsule, lateral capsule, all the capsules were released. So of course, I was having a lot more blood loss in the first, at the beginning of the learning curve. But as you can see, the transfusion was less, but I think the transfusion was less more because of the TXA. We use tranexamic acid for all these cases. Years ago, we didn't use it because it's a long time too, so we didn't use TXA. I think we started using it in the last 4 years. The post-op, that was one of the most important things, that we were able to send the patients home faster and discharge the patients in faster than with the direct anterior approach than the posterior approach. And the measurements of the stabular inclination, leg length discrepancy, and femoral offset were better with the direct anterior approach. But I think those changes are because we have C-arm through the case. My goal is after 500 cases or so, not using C-arm, because when you get the feelings, you really need to use a C-arm eventually. But I'm not at this stage yet. But I'm getting close to stop using C-arm altogether. So pretty much in my review, there were similar patients. I put bigger cups and bigger heads stems on the posterior approach. On the direct anterior approach, there was a little more blood loss and 10 minutes more of surgical time because the explanation I told you at the beginning of the learning curve, the first 50 cases were included. Less transfusion, less length of stay. So the patient were able to leave home the day after surgery. They were discharged to rehab, 35% direct anterior approach, 60% posterior approach. And the inclination of the acetabulum and offset were better on the direct anterior approach. In terms of complication, I have one complication, 92 years old with the intraoperative fracture. When we were reaming the calcar, I remember we stopped reaming the calcar and restart, and we have a little fracture of the calcar, so we have to put some cables there. On the direct anterior approach, we have one patient who has an infection. There was a patient with serratia, 60-year-old with the HIV and Hep C. I remember I did the opposite hip posterior approach. I decided to go with the anterior approach, but he was admitted 4 months before with septicemia with serratia. So he got better. He was discharged a month after that. He got some changes on both sides on the femoral head on the socket side. I think my mistake was not aspirating that hip, but he was having the same changes on the hip on the hip that I did years before. So after I did the surgery, 6 weeks after, I saw radiolucency around 3 millimeters radiolucency around the stem. I said, "Oh my God!" And I saw I have to revise this patient. I aspirated; it was negative. But when I revised, I did one stage exchange, and the fluid that we sent for cultures showed that it was a serratia. So he has but he did very well after the revision, one stage exchange. We have two. I have two minimally displaced great trochanteric fractures, but they all heal fine. I remember when I have these two cases. I think there was case number 10 or case number 13, and I called Dr. Parbisi and said, "Oh, Dr. Parbisi, I have these patients with a couple of fractures," and I remember he told me, "Hey, Jorge, if you're comfortable with the posterior approach, you can just stay with the posterior approach. Don't worry." But my feel was, I can continue to do this. Why am I going to stop? So I continue, and now this is my main technique, my main approach, direct anterior approach. But yeah, those patients heal fine. Like he told me, you just don't, don't do active extension for 6 weeks, and they heal fine without any issues when it's a minimal displaced great trochanteric fractures. Uh, uh, my feeling is this direct anterior approach came to stay. This approach is a major technique, and like I told you, all my residents know more direct anterior approach than the posterior approach, because they go to Leahy Clinic, they go to BMC, and both places they do more anterior approach than posterior. So it came to stay. But I think for me, the posterior approach is still the workhorse. For other revisions, I still do. I'll do them with the posterior approach. And I think is the most proper approach in the future there. Okay, well, and remember, use the mask and stay with social distance, so we can be able to fight this issue that is causing us a lot of trouble around the world. And when you welcome to Boston, and thank you very much. If any questions, please let me know.
Thank you, Dr. Villafuerte, for that fantastic presentation. And it was new insight for a lot of surgeons who have been doing the posterior and the lateral approaches, because DA is still not, very few surgeons are doing it. And of course, it's like you said, it's catching up very fast. Few questions that have come up. Dr. Villafuerte, there are a couple of high quality RCTs. One was actually published in Acta Orthopedic in 2018, which was actually a prospective randomized controlled trial, and they found that the incidence of complications were slightly higher. Of course, they could be in the early series, but like implant malpositioning and femoral stem fractures, femoral side fractures. So of course, there are a lot of RCTs that really looked at exceptional function, early return to work. So what is your take on that with respect to complications?
I think if you are an experienced surgeon, like I said, your complication rate will be less because you have more experience. If you're an experienced surgeon, 5 years, 10 years experience, if you decide to change for the anterior approach, you don't take anything lightly. So you take a C-arm. The keys at the beginning, for personally, I don't use a rasp to start doing the broaching of the femur. I use the rat tail, so I can really is dull, so I really can find where the canal is located. So when I find when the canal is located by hand, I start rasping from the rat tail medially all the way to the calcar and laterally all the way to the cortex. So you really know where the canal is placed, is located. Secondary, after that, you start broaching. The first broach goes by hand. You don't have to use a mallet when you put the first broach. So you put the broach, you just slide the broach by hand, and the broach should go down by hand all the way. This is the key to avoid complications like that kind of complications with fractures. And the third thing that I would say is, after you start broaching, when you get the feeling that the broach is getting tight, you get a lot of extra because you have the C-arm with you. So you know where you're located. You get a C-arm view, an AP and lateral to see how much you have to go in place. I think that's the key. Of course, at the beginning is not easy because it's a new technique, new approach. But after you would be able to master the technique and everything goes smooth, you get used to it and the complication rate is decreased. But if you take this kind of things lightly, it's easy to get into trouble. So I don't have any fractures, thank God, so far, right? But at the beginning of the learning curve, if you don't take that very, very carefully, you can get in trouble easily on complications like this.
And is the femoral nerve at risk? Is there a chance for a femoral nerve palsy? I mean, a couple of authors have reported a transient femoral nerve dysfunction.
I have some patients with femoral cutaneous nerve palsy or paresthesias. I have many, and I've seen that described in the literature is more than you think. What is described as a femoral cutaneous nerve. I don't have any femoral nerve palsies. I put just one retractor. I put just one cobra right on top of the transverse double ligament. Really, there's a lot of soft tissue from there to be able to hit the femur, the femoral nerve. What I see is femoral cutaneous nerve paresthesias. I see more than I think, but they don't complain much and they get better. So after you make sure you're lateral enough on your incisions to decrease the lateral cutaneous nerve. But I don't see that. I mean, I think if you place one retractor right on top of the transverse double ligament, some people put a retractor right on top of the superior corner of the acetabulum. I think that retractor, if you push it very hard, that's when you get in trouble too. The problem is when you start changing from the posterior approach to the anterior approach, you try to see everything. And with the anterior approach, you're not going to be able to see everything. You have to really wiggle the cup, wiggle the reamer to be able to get it in. What I do is personally, I get the reamer in reverse. So you get it in reverse, wiggle it around. So pretty much the reamer slides in and goes in very nicely in reverse. So you don't go forward. So you don't push it, just wiggling it in. So you just wiggle it a little bit and the reamer goes down just by reversing. And another thing that I do is the lateral cover that I place sometimes when it's really tight. When you finish reaming, you slide the reamer right on top of the lateral cobra, and the same way you get it out, the same way you get it in. You slide it right on top of the cobra and you reverse it and it goes in very nicely. So yeah, putting many retractors, that's when you get in trouble too, in terms of femoral nerve palsies.
Thank you, Dr. Villafuerte. Dr. Villafuerte, Dr. Senthil Sambandam is also online in our Zoom room. Senthil Sambandam is a staff orthopedic surgeon in Texas. Senthil, your questions to Dr. Villafuerte.
Dr. Villafuerte, excellent presentation. I've seen you operating. I've been in some cases with you for the anterior approach, and you're very sleek and quick, so I really appreciate your technique. So I know you use your C-arm for your surgeries at this point. For the beginners, what are all the points during which you use your C-arm? Like, what are all the steps during which you think you should confirm it with the C-arm?
Well, at the beginning is at the learning curve, you really have to put the C-arm when you start doing the cup, when you start reaming. So when you start at the beginning of the reaming, you make sure you're in the right place. I personally now I use the reaming just when I reaming. For instance, I have a size 56 socket, so I start reaming with 49. When I go to 55, that's when I use the reaming. So I pretty much put the reamer down and I take an X-ray just to make sure I'm like 5 millimeters to ream down. So I put the reamer down, take an X-ray, and after I ream, the reamer goes this 3 millimeters that I need to go 5 millimeters. So I get the reamer out, and I don't use trials. What I learned this with Dr. Estock. I trained at the Brigham, so Dr. Estock was my teacher. So he, instead of using the trials, he used the same reamer. So I put my reamer down after ream 55, and I take an X-ray, and I'm able to see if the reamer is all the way down, and I'm able to see if the reamer has some tightness. I ream 55, but you get some purchase. So if you get a little bit of purchase with the 55, you know that the 56 will fit very nicely. If the 55 is pretty loose, so you know you have to go higher than that. So that's when I get X-rays, pretty much on the last reaming. On the femoral side, at the beginning of the learning curve, my advice is as soon as you use the rasp, you find your canal, blunt, find your canal, you know where you go. The first broach goes by hand. If it's a size 13 stem, for instance, You find your canal, you start broaching with 7, you go up to 10. When you go, you get in tight in 10. Now there's a time to get an x-ray. You get an x-ray lateral because most likely you're tilting your stem, or you might be tilting your stem, and you might be going medially on the femur. So that's when you get into trouble, because you have to hug the patient. That's what everybody says, hug the patient. You have to medialize the handle so you avoid going to the medial cortex. Or if you're in 9, you know you have to go to 13, it's not going in, you know you have to change your approach, or you have to go a little more lateral, or you have to broach or grasp a little more medially at the metaphyseal bone, so you can go in a better positions, because the problem is going onto the medial cortex. And if you continue to push in that direction, you definitely will crack the medial cortex. So pretty much in the C-arm and the femurs is mandatory at the beginning. So now I really, if I got the good feeling, medial enough, you, like I told you, you interrotate the handle, medialize the handle, lateralize the handle, you know, in a good position, you take a C-arm right up before you put the implants in.
I also noticed that you use a Bowie to mark the neck cut, right? You still do that?
Yes, I do that. I think it's because I think after you get hundreds of cases, now I'm getting ready not to even do that. I have a bad experience on a case. You have to get the technique to the radiology tech to get an X-ray. So in one case that I did, the radiology tech was not there, so I just cut the neck, and it was that patient who has an infection, and I cut the neck too low. So since then, because it's hard to see where is the location of the lesser trochanter, you don't feel it very well because it's a tight space. So you guess a little bit the location. But now after you do 100, you can really see, because you do an inferior release. When I do the cap now, I do an anterior capsular release, and I do inferior capsular release, and I can really feel where the capsule is located and where the lesser trochanter is located. And from there, I go 15 millimeters or so, and you can really see where the cut needs to be done. But at the beginning, it's a good idea to take a look where the neck cut has to be placed, because if it's too short, now you get in trouble and you have to get the length, put the stem higher or something, and get a bigger size to be able to, compensate for shortening of the component there.
And you use the short stems these days, and you had good experience with it?
Yeah, I'm still using the short stem, and I think the key there is to have it as tight as you can. So the position of this component is the key. So you really need to rasp to make sure you go into the cortex, because if you're not there, you can have trouble with subsidence. That's what I've seen too. So you really need to template, make sure the size is appropriate. And if you have if you template for size 15, if you're tight in 11, you're not in the right place. You really need to rasp well. You're not the wrong location. So you have to rasp and figure out where it'll go to be able to put the stem in the right place.
Sounds great. Thank you very much. It's a really good presentation. Hitesh, I don't have any more questions. Do you have any questions?
Yeah. Just one last question before we conclude. Dr. Villafuerte, what are your post-op rehabilitation? What do you advise your patients to? Any particular movement restriction?
Well, that's a good question. I didn't go over with that. Pretty much the presentation was thinking to talk about anterior approach and COVID, because this is a major change with COVID. Now with COVID-19, the key is to get the patients out of the hospital as fast as you can. So pretty much all my patients are leaving the day after. There's no restrictions. The idea is to, if it's a younger patient, ASA2, ideally is to send the patient even home the same day. You can do the case in the morning, the patient should be able to go home in the afternoon. I can't do that here because we can't do the cases in an outpatient facility, because in Jamaica Plain is not allowed for us to do outpatient surgery, and our patients are more difficult to send them home because of patients' issues. But in private sector, the patients really don't want to stay in hospital. They really want to go home. Everybody more to decrease exposure, they want to come, get the surgery, and go home the same day. So pretty much with the anterior approach, you can do the case in the morning and send the patient home in the afternoon. So now what we're doing is sending those patients, all the patients with the anterior approach, go home the day after. No restriction. They can get the surgery in the afternoon. They're going to the bathroom, they're walking, doing steps, doing all these exercises without restrictions or motion or anything, because you test that right before you close, so you know that the hip is stable, so you don't have to be concerned about stability. But the learning curve is an issue. That's definitely the problem. So At the beginning is the hard part. I think the first 50 cases.
And do you think if you start with, say, hemiarthroplasty, doing a lot of cases with the direct anterior approach, switching over to a total hip would become a bit easier?
My feeling is if you have experience with any approach for years, I think you can change because you have the ability to feel and understand the hip more than somebody who hasn't done it. You're more cautious. At the beginning, sometimes when you're out of the residency, you think that you're there, you're not. I think experience makes a difference to make the change. But of course, if you're in the residency, if you're exposed to, like my residents are exposed to more direct anterior approach than the posterior approach, they will know better. But for us that we are, if you are practice for 10 years or so, to change is not easy, but you're more careful. So you use all these advices from everybody else better. So you don't take anything lightly.
Thank you, Dr. Villafuerte. I think that's we don't have any more questions. Thank you for joining in. It was a really, really great experience. We all learned a lot about this new technique. Of course, it's there for quite some time, and we really got a lot of new information from your wonderful lecture, Dr. Villafuerte. Thank you once again for joining me. Thank you, Senthil.
You're welcome,
Thank
Dr.
you.
Capallan and Senthil. Thank you for the opportunity and stay safe.
Yeah,
you very
thank you.
much.
Thank you, Dr. Villafuerte. Take care. Bye-bye.